Right, good afternoon, everyone. A very warm welcome, and thank you for joining us on our Arthrex Ortho Engage Coffee Room series. Before we begin, I'd like to start with some information and some housekeeping rules to ensure a smooth, trouble-free session. Firstly, it is my legal obligation to inform all our guests that this session will be recorded and will be available on arthrex.com. And in addition, these sessions will be broadcasted live on social media platforms such as youtube.com. I would like to now take this opportunity to thank and introduce our international faculty, Dr. Luke Ciccinelli, originally from the United States, but now practicing full-time in Vigo, Spain, as well as Professor Mohammed Nassif, specialist foot and ankle surgeon from Cairo, Egypt. Both gentlemen have a wealth of knowledge to share with us this afternoon. Gentlemen, thank you for taking the time to join us in these unfamiliar circumstances that we see. Thank you for your contribution. It is highly appreciated. As you can see, this is our second live video session of a comprehensive program we've put together for you. I'd like to invite you to join us for any future sessions that may interest you. Next week's showing osteotomy around the knee on the 20th of April and ABCs of ankle arthroscopy on the 22nd. I'd like to also take this opportunity to thank all our healthcare professionals from around the globe for their courage, compassion, and dedication during this global crisis. We salute you. Before we move on to the main event, I'd like to highlight some important points and allow us to share the information being shared. I'd like to request everyone at this point to please ensure that your microphones are muted, as this will create a calm and relaxing atmosphere for everyone to enjoy. During the Q&A session, we have two options. You have an option to upload your questions on orthoengage@gmail.com. This is for the people joining us from outside the network on platforms such as youtube.com. And for those of you joining us on Microsoft Teams this afternoon, you can place your questions directly in the chat box. I'd like to now hand over to our moderator for the session, Dr. Mohammed Nassif. Dr. Nassif, over to you.
So, hello everyone. It's great to be here. Thank you, Mike, for the intro. It's a pleasure to be moderating this first foot and ankle webinar. This is the second Arthrex webinar, and the first one was just yesterday. And we're proud to say that we had almost more than 400 individuals that were participating between the Microsoft Teams platform and the streaming live YouTube. As Mike said, that will also be available for later viewing if you want. So we hope this event will probably be perhaps not the last or the least in a long line of webinars, but we do also hope that we return back to our normal life, as we will later on, and we are sure that mankind will prevail. It always does. So without further ado, this is the first foot and ankle, or DEX, webinar, as we said. There's still a long line of webinars related to the foot and ankle, as we alluded to, and Mike will show you these as we progress or towards the end of our session. It's a very, very great honor and pleasure to introduce Dr. Luke Ciccinelli. He's a great friend. We've known each other for quite a few number of years now. He's very well learned and eloquent, and he does have his own philosophy of foot and ankle. So, Luke, are you ready?
Yes, Nassif, thank you. Welcome to everybody.
The floor is yours.
And I will go ahead and start to share screen, if you could confirm that.
While Luke is bringing up his presentation, you guys can use on Microsoft, use the question and answers for Luke's talk if you have questions that you would like Luke or me to try and answer for you. And those, as Mike said, that are on the YouTube, you can also send them into the email he brought up, orthoengage@gmail.com. Okay, Luke, you're ready to go. I'm muting mine.
And you can see me just fine, Nassif? My slides?
All's perfect.
Okay, thank you very much. Well, welcome everybody. Certainly a pleasure, and we'll just jump right into this, treating the modern day Flatfoot. I certainly enjoy this opportunity to speak, and I am passionate about Flatfoot. And the goal here today really is to foster some questions, a bit of controversy or debate perhaps, so please send in your questions, and Nassif and I will do our very best to have a interchange about them and answer them. I think probably, I love this quote by Sir William Osler, that medicine is a science of uncertainty and an art of probability. I think really, particularly elective reconstructive foot and ankle surgery, perhaps not so much trauma, but elective reconstructive foot and ankle surgery really is a blend of science, which keeps advancing, of course, which is wonderful, but really art as well. And I think if we were to summarize it, perhaps it would be like a painter or a cook, where people are choosing their own colors or choosing just what they find works best in their hands to create the pictures and the outcomes or the recipes that they would like. And I always like this picture of a stillborn dissection of Talipes equinovarus, because and you would wonder, why is it in a Flatfoot lecture? Well, we can just see from the picture so clearly that the talus, by virtue of having no tendinous attachments, is really just passively involved in so much of foot and ankle pathology, again, perhaps accepting traumatic events. But you just see that the foot is spun around into the supination and varus and adduction deformity around the talus. And so really, quite frankly, it's a triplane type deformity. And like so much of life, the opposites define each other. We're all here in confinement and homebound and so forth, which is a wonderful example of how the opposite of our current situations is now contrasted with our very hectic and busy lives prior. But so if we just look at the exact opposite of a triplane deformity, well, a Flatfoot is really just the opposite of this. The foot is spinning laterally, everting, and plantar flexing in a sense around the talus, but in the other direction. And so if we look at the different planes, again, if it's a triplane type deformity, and we can think about perhaps a planal dominance approach to procedural selection, which is really what we'd like to discuss today, I'm going to give some background, because I do think the background of how I look at the foot and things I've learned and read over the years, certainly from the literature, certainly from my professors and colleagues, of course, all of it kind of in the net sum, is procedural selection is really the key to trying to sort these issues out for our patients and ourselves. So if we look at a triplane deformity, well, the frontal plane perhaps is heel valgus, and how do we get the heel to be in a more rectus position? If we look at the transverse plane, well, it's abduction through the midfoot and mid-tarsal joint, perhaps a bit distal. And we think to ourselves, well, what are the options to align the foot in the transverse plane? And then in the sagittal plane, perhaps starting with Aquinas in the posterior muscle group, but also in the medial arch. And how can we take some of these very, very flat feet and get a functional, and yes, aesthetically a pleasing arch, but not necessarily the main goal, but certainly a functional arch. And realizing that within each of these cases right here, there's actually been one or two or possibly 3 procedures performed to try to solve the issue. I do like this bit of a summary slide I put together here, and I'm not going to try to bore you or death by PowerPoint here, but it just really is important for me to share this perspective, because it's the accumulation of many, many, many years of chewing on Flatfoot and how we approach it and how we understand it. And I just like kind of the combination of these 5 gentlemen's way of thought. And the foot plate of the lamina pedis by Rationale, who basically described the foot as an osteofibrous mass, which essentially says that the foot is a bunch of bones connected by ligaments. And as long as those ligaments, and by the way, that is accepting the talus. So the talus belongs to the leg. So we have a foot plate below the talus, which is all connected all the bones connected by the ligaments, and essentially the closed pack configuration and intact ligamentous constraints allows us to function as a foot plate that rotates around the dorsiflexion, the acetabulum pedis. Okay, so the acetabulum pedis is what really receives the head of the talus, and we have this calcaneonavicular osseous and yet spring ligament complex as well. This is old literature by Basmajian, which says that the foot is electromyographically silent static stance. That we know from recent literature over the last 10 years, so that's not completely true, but it's certainly true enough to make the point that the intrinsic musculature are really stabilizers. And what we're trying to do here is have a stable foot that's connected by bones, and as long as all the ligaments are intact, this closed pack configuration of the foot functions very well. And then Hicks talked about essentially the Achilles calcaneoplantar kinetic chain and the windlass mechanism, which we now get into gait and function and dorsiflexion of the great toe and propulsion as we go through the three rockers, from the first rocker to second rocker and third rocker to propulsion, and really asking a foot to stably function, particularly along the medial column. And then in Dr. Hansen's book, Functional Reconstruction of the Foot and Ankle, I really have used quite a bit and still do his concepts of the essential versus non-essential joints, where he basically categorizes all the joints in the foot and ankle as to those that are more essential than non-essential, such as the ginglymus and round surface joints, such as the talonavicular joint or the metatarsophalangeal joints, are really essential for good locomotion and good movement forward. And then the short bones, the intercuneiforms, tarsometatarsal, and so forth, are less essential and more built for stability. And we can use those categorizations of essential versus non-essential to help us as we plan our procedures to try to stabilize flat-foot. So here, basically, these ligamentous constraints, this osteofibrous mass of bones from Rationale, the windlass mechanism here, the attachment of the Achilles calcaneoplantar chain, the kinetic chain, creating a nice stable arch for dynamic function. When all this works well, and we have these bones in their closed packed configuration, which essentially does what? It essentially screws the joints into place. The ligaments tighten, everything's compact, everything works like one solid chain. And as we go through propulsion here into first rocker, second rocker, and on to third rocker, everything functions really well. And all the muscles and tendons are working well and in concert. And the acetabulum pedis of the foot.
Sorry, Dr. Luke.
Yes?
Can I just interrupt you? Just ask you to share your screen again, please.
Okay.
It seems someone may have interrupted you. Thank you.
No trouble. Let me see here. Let's go back to that. Don't know what happened.
Someone may have joined and then shared screen. So if you wouldn't mind just doing it again, we should be back up and running. Thanks.
Okay. Am I back there?
Just on. Yep. That's good. Thank
now
you.
You're back.
Okay, very good. So the acetabulum pedis is, again, this foot plate that is receiving the leg above, and particularly the talus. And I always like to emphasize that the talus really belongs to the leg and not so much the foot, because it's the torque converter. The internal and external rotation of the leg are converting those forces through the talus and the acetabulum pedis, and the foot is spinning and rotating beneath that. And so this is from Rationale, as well as referenced in Serafian's wonderful functional anatomy of the foot and ankle textbook. And I just really like this. If you look at the external rotation on the upper right of the talus, which again is coupled with the leg, we see the foot through the medial arch, particularly the navicular cuneiform joint, supinating and pronating to keep the medial column on the ground. Alternatively, below that, with internal rotation of the leg, the tib-fib segment, through the talus, converted down into the foot, or torque conversion into the foot, we see pronation and supination through, again, the navicular cuneiform joint. And so he described the foot really as a twisted plate that as it supinates, twists further, and as it pronates, it untwists. And I like to add in there that I really view the first ray as so critical in the stability of the foot. And again, these background points that I'm sharing serve completely in the way I view trying to then stabilize a symptomatic flat foot. And so I call the first ray, or a stably plantar flexed first ray, the kickstand of the foot, as in the kickstand of a bicycle. And when it's functional and when it's stable, the foot just really functions really well. And we know that's true from the contrast. Again, I like to talk about how the opposites define themselves. And if we think of the worst cavus feet we've seen, with those rigidly plantar flex first rays that can actually drive the whole hindfoot deformity themselves, then we can really appreciate the opposite as well when we have first ray insufficiency due to ligamentous tear, perhaps attenuation of ligaments, perhaps previous hallux valgus surgery, perhaps first ray shortening, and so forth. Then the bicycle falls over, and as the foot starts to collapse, well, everything starts to change, particularly functionally. And of course, functionally is how we're trying to help these patients. So as that foot starts to collapse and the kickstand no longer functions, and we have that insufficient first ray, well, then we start to see how these mechanical effects start to happen. And we see the inability to completely, on another patient, invert the heel on toe raise, and we start to see how the foot abducts and the too many toes sign, and all these classic signs that most folks are, of course, familiar with looking at and evaluating with their patients. And then we can appreciate as well that back to the importance of the ligamentous constraints and them being intact in a well-functioning, stable foot. We see here examples of sprig ligament tears and posterior tibial tendinopathy. We can see here on the left, we see a spring ligament tear more at its proximal side, and we see a spring ligament tear at its more distal side. And just showing, again, really emphasizing in my view of how the foot works and how we try to return its function the best possible, the importance of really that navicular cuneiform segment on the medial arch. I think really what this all comes down to is when we get faulty foot mechanics, for all the kind of combinations of things that I just discussed, we're really getting an altering of the balance of power. And in a reconstructive effort or a stabilization effort, what we're trying to do is alter that balance of power back to a more functional foot plate, foot structure beneath this talus and leg. And I really like, it is a long conversation to go into, and people much brighter than myself in the biomechanical and research world. But really what we're talking about here is tissue strain and pressures, and understanding that pressure and force are intimately related. Pressure being force divided by area squared, or millimeters squared, for example. And the vectors and the moment arms of tendons and the extrinsic musculature really being pulleys that are creating the power and the movement and the vectors. And so not only in a pathological sense, I think it's really important and even fun and engaging. And as we talk with each other, and we all try to keep polishing the diamond, so to speak, on how we understand and how we evolve in our treatment of things, I think it's important and fun to think about, well, let's take the pathological foot and think about how the tissue strain and where the pressure is and how the pain that they're having, the patient's having, relates to tissue strain, pressure, and forces, and how the altering of those mechanics can really affect how the extrinsic musculature works as well. And here the central line is the subtalar joint axis, and we just see how in different feet, pathological and then corrected, we can be altering exactly how those vector and moment arms work. So if we go into some of the treatment options, well, what's the goal? Well, the goal is to unspin the foot and get it back stably underneath the talus. Again, the talus is basically passively involved. The foot is unspun out from underneath it, peritalar subluxation of varying degrees of severity. And so here you can see a very well corrected flat foot in a very young patient, about 5 or 6 years old, years ago. And just seeing here a neutral position x-ray taken preoperatively, and then capturing that with a arthroresis or extraosseous talotarsal stabilization in a very young patient. I will say that I personally don't really operate on any children younger than 10 years anymore, 10 years old anymore. I really watch and observe and wait on them. I think there's some good literature out there throughout the last bunch of years that really shows that the arch can really continue to improve even up to 10 years of age. If we then think of other ways as we go through now into some of the more common procedures and get into some of the conversations on procedural selection, which will be where Nassif and I start to discuss more and take your questions and so forth, we're still trying to optimize or create more favorable supinatory forces. We're trying to diminish pronatory forces. We're trying to favor supinatory forces. So certainly the medial calcaneal displacement osteotomy, trying to medialize the pull of the Achilles tendon and get that heel even in the first rocker to land in a more mechanically functional position. Certainly there's lots of ways to fix these osteotomies, be it step plates or screws of different varieties in younger kids. Even smooth K-wires through the growth plate are certainly acceptable, as they'll be retrieved later. If we think along the lateral column, and here we could get into a bit, perhaps in the discussion of the columnar approach to stabilizing flat feet, looking at the lateral column versus the medial column, and understanding with Flatfoot, symptomatic Flatfoot deformities, that the lateral column is compressed and the medial column is distended or stretched or lax. And so, again, going to the opposite of the deformity, seeking stabilization or correction, what are we trying to do? Well, we're trying to decompress the lateral column and compress the medial column. And then our decisions, of course, come. Do we wish to do that through osseous procedures, through soft tissue procedures, or combinations of both, right? So here, the Evans calcaneal osteotomy to decompress and lengthen that lateral column. And it's always fun to remember that was first described by Dilwyn Evans as a procedure that he started doing and experimenting with for the correction of overcorrected club feet. And here we are all these years later. It's a very popular and well-known procedure for flatfoot correction. Again, to emphasize a bit of the concert or the synergy between the soft tissue components and the osseous components of trying to stabilize symptomatic flat feet, I think it's always worthy to remember on this lower right-hand slide where we see the lateral projection. I don't know if you see my arrow or not, but we see how the lateral column improves in its arch height as well. So the lateral arch height with the use of the Evans calcaneal osteotomy, whether you make it distally here or as Dr. Hinterman has described, doing it more proximally, we get an elevation here which can actually potentiate the pull of peroneus longus as it courses underneath this area, under the cuboid, and then inserts into the first ray at the plantar aspect of the first metatarsal and partially at the base of the medial cuneiform. So we can see how the osseous reconstructions can also help potentiate the soft tissue components as well. So lateral column lengthening, of course, can be performed in various fashions with various devices, be it plate fixation or simply bone grafting. But the idea is to lengthen that lateral column and bring the midfoot back around and rearticulate it or recover the talar head. And by recovering the talar head, we help drive or reduce the peritalar subluxation and drive the foot back underneath the talus, and then the talus back more stably into the ankle mortise. Again, we can never forget about the first ray. To me, again, I'll just say again that I consider the first ray really to be critical. Again, the kickstand of the foot, so to speak, to use my bicycle analogy. And to me, it's really where I always look first and where I always end up looking intraoperatively. And here, certainly the cotton procedure is a standby for plantar flexing the first ray in the medial column. But not just osseous procedures. I happen to be a big proponent and a big user of the navicular cuneiform fusion, and I don't want to shortchange either soft tissue procedures. I think there's very stable, reliable soft tissue procedures for the medial column, such as the modifications of the Kidner procedure, the Cobb procedure, rerouting of the tibialis anterior tendon through the medial cuneiform, for example. Or alternatively, the Young's tendo suspension or the weak foot suspension that was historically called through the orthopedic literature over the decades through the navicular to stabilize the medial column. But if we return to what they're all doing, they're all trying to stabilize which joint? The navicular cuneiform joint. And to me, really, that's where everything begins and ends with the medial column. Internal brace augmentation of the spring ligament is certainly a very novel and unique idea that's come along in the last several years, at least about 6 to 7 years now. And I think there's some excellent work out there. I always like Chandra Pasapula from the UK's wonderful study he did on the resistance to failure of the spring ligament, and seeing here with the internal brace seated into the sustentaculum tali region here and routing it through in combination with an FDL tendon transfer through the navicular tuberosity. And based on Dr. Pasapula's research, I actually, let me go back one slide, they actually bring both bands of that internal brace augmentation down plantarly now instead of one up high. This was the original article, so to speak, by Jorge Acevedo and Anand Vora, where they studied 26 patients. And I just kind of use this to now segue into a couple cases and onto the Q&A to show that in the additional procedures, this really speaks to the issue with procedural selection and really studying how to manage flat feet, because there's such a variability amongst surgeons, amongst patient needs, amongst our training backgrounds, amongst our own philosophies, perhaps amongst our own conditioning, if we're all honest with myself. And I'm sure I'm conditioned to do certain things, absolutely. But we can just see the variety of the additional procedures that are done. And so when we try to study all this, and we do have classification schemes and grading and so forth, but they help us, absolutely, they help us communicate with each other, help categorize patients, and in a research sense as well. But still, there's so many variables because, again, back to painting, someone may add in one color, or back to cooking, someone might prefer a bit more salt or less salt or a bit more oregano. And so we really have quite a task on our hands. So I think it comes down really to, of course, understanding the foot mechanics and having our own view and vision and clinical assessment of how these patients are really functioning. Where is their pain within a foot that may have multiple pain points? Where is the tissue strain? Where is the excessive pressure? And what is it doing to the real kinematics of the foot? Open kinetic chain versus closed kinetic chain, seated exam versus functional exam. How are they actually functioning versus just sitting in a chair where they may have a completely reducible mobile foot, but yet doesn't function that way in the closed kinetic chain. And so I thought I would just put two case presentations here, contrasting procedural selection in two cases, and I've clearly watered down the background information. I assure you, I don't operate on anybody with flat feet that are not symptomatic. I've seen wonderful athletes and people and friends and colleagues who have flat feet that don't bother them at all. I'm not a person that corrects asymptomatic flat feet. So these two patients are just kind of classic examples of people who've exhausted conservative care. They have unremitting pain in their feet, or in the 14-year-old's calves as well. Even the 62-year-old's some medial knee pain. They've exhausted conservative care. It is affecting their quality of life, and they just become surgical candidates. So if we look at the 14-year-old, and I've purposely chosen two cases, just contrast a few different procedures and foster some debate and conversation. And Nassif has a case he'll share as well, which adds to this. They're very complementary. So obesity, unremitting arch pain, failure of years of non-operative management, and BMI trending upward. Okay, and unfortunately, when our feet and legs hurt and we just can't be as active as we'd like, or our parents would like us to be, or keep up with our peers, well, it becomes an issue. And the procedures chosen there was the combination of what you see there. So a medial calc slide, a navicular cuneiform fusion, and gastroc recession. Alternatively, in the 62-year-old, previous first ray surgery with residual hallux valgus, and yet not her chief complaint, and quite frankly for her, it doesn't really bother me. It's not my main issue. Yes, everyone who evaluates me looks at my x-rays and says, geez, that doesn't really look like a great correction you had on your hallux valgus. And she says, yeah, but it doesn't bother me. What really is bothering me is my medial arch is killing me. And I have medial knee pain. MRIs in her case, negative for posterior tib, North spring ligament pathology, but positive for some mild DJD, osteoarthritis of the subtalar joint. And so I chose subtalar joint fusion and a cotton osteotomy in her. And so in this 15-year-old, I just show you the comparison of one foot corrected versus the other, and he'll be coming up for the other foot, but just showing a nice stable correction visually and functionally. And he is a large child. He's got a high BMI. And when I look at these x-rays, the things that I just want to share in this kind of, coffee chat format here, Nassif and Mike and I and you all, we're all just sitting in a lounge somewhere having a cup of coffee and chatting about these things, more colleague to colleague rather than a scientific meeting, academic meeting. These are the things I really look at. I look at what's called the broken cyma line, the blue lines there, how the talonavicular and calcaneal cuboid joints just don't really line up. There's no continuity there. I look at the subluxation of the navicular on the cuneiform in the medial column and the declination of the talus compared to the first ray. And what I'm looking for post-operatively to stabilize this type of foot is a more stable osseous architecture, where I now see a continuous cyma-line. I see a solid navicular cuneiform fusion that I've done. There's no further subluxation. I have excellent coaxial kind of parallelity between the talar bisection, the first metatarsal bisection. We can see a very nicely corrected foot there. Alternatively, here's the 62-year-old that had the residual metatarsal osteotomy, residual hallux valgus. And in her case, she has this broken cyma-line as well, but the navicular cuneiform joint is very stable visually by clinical exam, but I'm just sharing radiographically here. And so this is a case where I say to myself, well, what's the best way to deal with this? What's the best way to improve her midfoot mechanics through the Chopard joint, the transverse arch region, address her symptoms, which are really medial column, but also somewhat in the hindfoot. She does not have equinus in her case. And so I chose here to stabilize the hindfoot through subtalar joint fusion. And because her navicular cuneiform joint was stable, I chose, and her bunion, her first metatarsal, did not bother her. The hallux valgus did not bother her. I chose to stabilize that medial column through a cotton osteotomy. And so I just contrast those, and we can have all sorts of conversations now about why not a medial calcaneal displacement osteotomy, why not something else. And that can lead very nicely into Nassif now, and going on to the Q&A and how we'd like to develop the conversation and the debate, so to speak. So thank you very much. I hope that's a nice overview for you and just a little bit of food for thought to present some conversation amongst us all.
Okay, Luke, wonderful talk. Thank you very much. It does show that to start embarking on any Flatfoot case, you do have to know the anatomical and biomechanical basis behind what you're doing and what you're wanting to achieve. And there have been a few questions here, so we'll kind of try and throw these around between us. So first of all, there's a very general question which seems to have been asked by two people. So how does the Flatfoot or correcting a flat foot influence your knee and consequently your pelvic obliquity, if you would have one, or your sagittal imbalance in the spine? So how does a flat foot adversely affect the knee, and correcting it might relieve knee pain?
Right, so I think it very much does, and I think it goes right back to my comments about the kinetic chain and the coupling between internal and external rotation of the tibial-fibular segment through the talus down into the foot. And if you look very closely, for example, at some of your postoperative results with an Evans calcaneal osteotomy, a lengthening of the lateral column that recovers the talar head, you will see postoperatively that the patients will develop or return to more external rotation because the foot has been brought back under the talar head. The talus resumes a more elevated and lateralized position versus previously, and you'll get actually some return external rotation of the leg. Now, this can relieve medial knee pain. I've seen that as well, and I do think if we then again look at the opposites, we do have to say to ourselves, what about when there's pelvic tilt and internal rotation or medial knee pain or perhaps internal derangement or knee deformity prior to fixing a flat foot? And so this becomes which is more important and which is most worthy of alignment. And my feeling, particularly in adults, is of course that the knee should be addressed first by the orthopedic surgeon or traumatologist. I believe in knee alignment first to get the knee as stably aligned as possible and then address the foot. And in children, of course, that's the opposite because typically they won't have any sort of internal or deformity to the knee.
Okay, great. And there was also a question by a good friend of ours, Fabrizio Cortese from Italy. Hope he's doing fine. He was asking, I think it was in relation to your spring ligament augmentation using the fiber tape. Now, he was asking, do you do that as a single standalone procedure, or do you factor in an FDL transfer while you are correcting that component of the flat foot?
Right. So nice to hear your name, Fabrizio. Nice to have met you a few times back here. So hello. So that to me is never an isolated procedure. It is always with, in my hands, an FDL tendon transfer to reinforce the deficient posterior tibial tendon segment and then address the actual ligamentous component, both to do a primary repair of spring ligament and reinforce it or augment it with the fiber tape. So it's in combination. I have not done any spring ligament repair as an isolated procedure or augmentation as an isolated procedure.
But theoretically, of course, if you do have an isolated spring ligament tear that might evolve later on into a flat foot, a medial arch declination, if you will, you might want to repair the spring ligament and possibly augment that, if you will.
So good question. I would say yes, but still would be unlikely in my hands. And the reason would be why, because I want to hedge my bets. I always want something to put the mechanics and the levers and the lever arms and the pulleys to this more side of favoring supinatory forces. So even if I were to have a patient, for example, who had an acute spring ligament tear, I would say to myself, well, why'd they get that? Now, certainly it could be a traumatic event, but let's say it was an attritional tear, but just isolated. Their posterior tibial tendon is still functioning fine. There's no longitudinal tears and so forth. I would still hedge my bets, and I'm sure that I would still do a medial displacement calcaneal osteotomy at a minimum to put the vectors and the moment arms and everything back in more favor to supinatory type forces. I could just say in conclusion of that line of thought that I think only similar to bunion surgery in my career have I seen more kind of under-corrected or undercooked flat feet, so to speak. In other words, someone who's had an intervention and is improved, but not perhaps as much improved as we would like them to be. And so I really hedge my bets on that.
Okay, wonderful. There's also another question, and I think it's about choosing which procedure for what. And I think we will get into this later on in a while. But just to temporarily answer the question is, what is your algorithm for choosing an Evans versus a Cotton versus a calcaneal osteotomy when treating that particular flat foot? This was from Cadoza, if I'm reading the name correctly.
Right. So for me, it goes back to probably the second or third slide where I talked a little bit about planal dominance. So if I see a lot of heel valgus clinically, I'm more inclined to do calcaneal displacement osteotomy. If I see a lot of transverse plane deformity, which really signifies, more of an altered subtalar joint axis, then I'm more likely to do a lateral column lengthening. I will say, however, that over the last 15 years or so, I have very much shifted in my personal preference to more medial calcaneal displacement osteotomy than Evans calcaneal osteotomy, the exception in adolescent flat foot deformity with large transverse plane deviations. And the question is why? And the reason is I feel like some studies by DeLand in cadaveric model, and then about 20 years ago, quite frankly, I think it was 1999, Otis and DeLand, compared Evans calcaneal osteotomy, lateral column lengthening to medial calcaneal displacement osteotomies, and both procedures' ability to unweight or reduce strain on the medial soft tissues, and even the spring ligament, plantar fascia, and so forth. And really what won there was the medial calcaneal displacement osteotomy. And then there was a computational modeling type study with finite element analysis done, I believe it was out of Japan or China, I believe it was Japan, basically showing the same. So I actually am more of a fan of medial calcaneal displacement osteotomies nowadays than I am for Evans, with the exception of kids. And Nasa, let me just make one last point on that topic, and that is that we have to return, I think, always to function. The heel contact, or the first rocker, mid stance, or second rocker propulsion, or the third rocker. I want the foot in the best possible position right before it hits the ground, then so much at mid stance. I want both, but if I have to choose one, I want the best possible position as it starts to hit the substrate, gets subjected to ground reactive forces, and I want the foot as basically the heel in the most optimal position as it gets ready to contact the ground or first rocker.
So if I was following your line of thought, then you would consider your static structures as more important than your dynamic structures, just quoting on that gate phase there. So would you always do a spring ligament repair when you're thinking about your medial column stabilization? Well,
so if it's there, yes. But take my 62-year-old lady, and that's the reason I put her in there. She has a perfectly congruous, clinically and also radiographically, she has a perfectly congruous navicular cuneiform joint. And yet she hurts along the medial column. So, yes, I frequently will inspect the area of the spring ligament. And of course, if there's any problem there, I'll repair it. But let's say alternatively, I do a navicular cuneiform fusion in somebody. I do not feel the need to when doing a navicular cuneiform fusion, I don't feel the need to also repair a spring ligament. I feel like that kind of takes care of itself by doing that. But yes, back to the original slides that I put in there, that I always put in there. You're probably tired of seeing them, Nasa, from some of the meetings, but the twisted plate theory of Macanel, I just really believe that the foot functions correctly if the ligaments are intact, under intact ligamentous constraints. And so one of our absolutely primary goals in treating that problem is to return it as best we can to that exact same uninjured state. That's the ideal.
Another question here from Robbie. I think this is Robbie Ray from the UK, great friend of mine, and I guess you know him also. Now he's asking, when you do the spring ligament, and I'll answer this before handing it over to you, if you don't mind.
Sure.
When you're doing the spring ligament augmentation or brace or whatever it is, do you consider the deltoid at the same time? Do you consider them as one entity? And if so, what would be your fixation points that you recommend for incorporating the deltoid? Well, if I were to answer that, in my experience, I do not go for the deltoid at the primary time of the. I can see her smiling, and I'll leave the mic to you in a while.
Oh no, please.
Yeah, I believe that if you're doing that, you'll be doing it as an augmentation, as an adjuvant to another procedure in correcting the medial arch collapse of the flat foot, that part of the deformity. And I do believe that the flat foot entity is a multiplanar deformity. So I would not only go further beyond that break point of the subtalar and start going into the deltoid. Although vice versa, you might argue that in these, for example, asymptomatically treated supination external rotation, where people would tend to put them in a brace or in a cast, where there's this just oblique fissure of your fibula, and then there might be an associated deltoid. If you follow up these patients, you might find them transitioning progressively, or albeit over a certain period of years, into a flat fit. What is your idea of that, Luke?
I agree with you. Everything that you just said. To me, if I to answer his question as I best understood it directly, I do not routinely repair or augment the deltoid ligament just because I'm augmenting the spring ligament. However, I do think everything merits evaluation on its own. And so I think the best thing to do, particularly if you were going to get into the staging, let's say a stage 3 trending to stage 4 within the classifications of posterior tib dysfunction. Well, to me, it's just like, syndesmosis with the ankle, or like you just said about a high ankle sprain. You need to stress these patients. Once you have the foot stably, again, to me, I go back to the biomechanics of it. I just love that. Once I have the foot plate back where I want it underneath the talus, then I want to stress the deltoid ligament and see if it is insufficient. And perhaps it is insufficient and it gets uncovered, where perhaps clinical exam didn't necessarily elucidate that due to a variety of symptoms, and maybe we do pick that up intraoperatively.
Okay, another question here is from Arfan Arafa from Saudi Arabia. Great to see him on with us. He's asking about the algorithm, and I think we'll get into that just in a while towards the end. So stay tuned for that, Arfan. We'll kind of give you the way we think. How to choose which procedure for the Flatfoot. There's also another question from Salman. He's asking about the algorithm for juvenile Flatfoot. So he's starting right from the top. If you have an adolescent or a juvenile Flatfoot. So I think, as Luke said, no symptoms, no treatment. We do not treat them. And recently there's been these papers that have tried to even look at these asymptomatic flat feet. Would they benefit from arch supports or changing in orthotics or physiotherapy just because they have a foot that looks flat, but there's no symptoms with that? And the cost-benefit ratio has shown that there is no need for that. You do not treat an asymptomatic flat foot. Now, Luke, in his presentation, he said that he would not touch a flat foot that is, I think it was below 10 years. Luke,
I did
right?
say, that's kind of my cutoff.
Yes, because
I've become very much a watch and wait up until 10 years old.
Because also in our community, we see people, disturbed parents that are coming in with children 4 or 5 years, up to the 9-year limit. They have these terribly looking flat feet, and the child is just sitting there. He's smiling. He does everything. He's participating in sports. He might be on a certain team, and the parents are just absolutely pushing that they want their feet, the feet of their son or daughter, to look better, but it's functioning the same. So I think you're on me with this also, that you would not touch an asymptomatic flat feet, no matter how bad they look.
Well, again, personally, no. But I would like to compliment our Italian colleagues with the use of calcaneal stop procedures and arthroresis, and their very, very long, wonderful kind of background and history and contribution in that field and innovation. And so perhaps, that would be the one exception in different circles of practice tendencies or preferred practice guidelines. But myself, from my background and where I learned and trained and practiced for so many years and even still do, but I'm talking more about my background of 20, 30 years, I'm not interested in operating on asymptomatic patients. I would rather work through physical therapy, rehabilitation, orthoses management, and so forth, and watch.
So let's say you do have a symptomatic adolescent. This is a question from Shaw here. Would you use an arthroeresis? I'll start off. Yes, it would be an option. It's a minimally invasive. Arthrex have the Pro Stop. It's wonderful. It's very easy. Almost anyone can do an arthroeresis procedure. But as Luke alluded to, you have to see what other deformities might be present. So, for example, the arthroeresis, if you would, could equal to that correction of the hindfoot valgus or the subtalar pronation, if you will, and it can correct that component. But if the foot has also a very marked forefoot abduction or supination at the end, you might want to throw in something onto that. So that would also be a point to think about when you're using the arthroeresis. Luke, any other additional comments on that point there?
Yeah, sure. So absolutely I do. And that's my preferred procedure. In flexible, reducible, adolescent flat feet of the age, let's just say roughly 10 to 17 years old. And then back to my comments about the importance of the medial column. So I think it's very interesting to discuss and continue to think for myself always, right through intraoperatively, is after doing that, let's say a gastrocnemius recession plus arthroeresis, and I feel like I have the hind foot and midfoot stabilized or corrected or neutralized, is to then evaluate the forefoot supinatus or forefoot varus of the medial column. And then we have to ask ourselves, what type of patient is this? Is this a skinny, young child, athletic, or is this someone who's really trending toward being a higher BMI type individual and so forth? And how reducible really is that medial column? And these are subjective things. And each surgeon needs to make that decision on their own, because by neutralizing the midfoot and the hindfoot, perhaps with arthroresis, in some children, I've seen the medial column reduce on its own with no further surgery over the next several years with orthotic management. In other words, orthotics managing and supporting the correction of the arthroresis. In other kids, I'm not convinced, based on my exam intraoperatively, that first ray, that first metatarsal elevatus, is really going to desupinate or pronate or reduce. And so I may very well do a cotton osteotomy, or I may do a modification of a Cobb, Young's, Kidner type reefing or rerouting along the medial column to reinforce the plantar component of the navicular cuneiform metatarsal segment.
Okay, great, wonderful. Dr. Rajiv here, he's asking, when would you choose a TNT arthrodesis in a flat foot? So I think that would be in the stage 4. You have an already arthritic joint, but actually doing a triple arthrodesis has kind of fallen out of favor, and I think people are now shifting more towards the subtalar or even a talonavicular, a dipple or a double fusion, as opposed to a triple fusion. It's extra cost, and it doesn't really add much to the procedure. It might actually overload on the lateral side. TMT fusion, triple fusion, what are your thoughts, Luke?
Well, am I understanding TMT fusion to be the tarsometatarsal, so lapidus?
Yes.
Right. Okay. So I think you're going to speak to that a little bit with your case presentation, but absolutely. So if I am looking at the medial column, and I believe it's in our algorithm that we'll share at the end, which is just it's kind of a blueprint algorithm to give people a roadmap, so to speak, and they'll still choose their own destination, kind of metaphorically speaking. But so I look at navicular cuneiform stability. If there's navicular sag, if I feel like the navicular cuneiform joint is subluxing, and there's no hallux valgus present, then I'm going to address it there. If I find hallux valgus present or an unstable first ray medial column hallux valgus, then I will do the TMT fusion of the lapidus. And then if I find neither of those, then I'm more likely to go to the medial cuneiform and do the cotton osteotomy. That's kind of my thought process in a general sense.
Okay, we still have a few more questions here, but let me just, since you brought up the, lapidus, now you've said it, I'll just show this this case we have here, and then we can go back to the questions if the people
Wonderful.
Don't mind. So,
Sure.
Yeah, so I'll just share my screen. Is that showing properly?
Yes, now it is, Nassif.
Okay, so this is just the history of this patient. It's a female. She's 56 years old. She's actually very active. She loves to travel. She travels more than 5 times a year. She has bilateral midfoot and forefoot pain, which are both relating to the ankles, slightly swollen along the PTT. Both sides are painful, but she's complaining more about her right side. And she has big toe pain, midfoot pain, normal alignment of the ankle, or at least almost normal. She has had 12 months, a year of shoe inserts and modifications, and she does still continue to have pain. Now, these are her clinical photos, you can see there. Massive bunion, really flat feet, not so much of the hind foot valgus as you can see back there, but a real lessening of the arch. Now, would you consider this more a flat foot, more a hallux valgus? Would it be something you'd be wanting to treat? These are the x-rays. So the hindfoot alignment, the AP standing views, you can see the off ending of the first metatarsal tarsal there. Once more with the oblique views. And I went ahead and actually asked for a sesamoid axial view just to see how that first ray is sitting on the sesamoids. This is the right foot, the symptomatic one. well, at least the more symptomatic one. And we actually went ahead and got some CTs and MRIs. We were fortunate in this case. And that would be a question for discussion. How often would you want to add more investigations as opposed to a simple 3-view plain X-ray of both feet, so AP standing, lateral, and perhaps an ankle view? So, Luke, what do you think? What would you do something else? How would you approach this case?
Well, so I would approach it as you I believe did with the lapidus, and the reason so is because of the obviously very large first metatarsus, primus varus, and hallux valgus, but particularly the big question, of course, is, well, would you do anything else for the kind of flat foot appearance? Well, her heel is neutral, and her heel looks neutral, and there is on the AP X-ray, it looked like her talar navicular coverage was excellent. It looked to me like her hindfoot and midfoot were in really very good alignment. And so I think you did, you're doing the right thing by just addressing the medial column.
Yeah.
The talar navicular covering there is excellent, really.
Yeah.
Her long leg films, line up.
One of the questions here is there a weight-bearing lateral view? Yes, of course, there had to be. We routinely get them. I'm trying to pull it up here. I don't think I added it, but yes, there was a weight-bearing lateral view. So anyway, just for the sake of time, we went ahead. Now, what I usually do is I fluoroscope these first. Now, and I have this little test I do. Under the fluoroscopy, I compress those rays together, so manually with my fingers, and see if it's correctable. Now, this gives me the kind of impression if correcting that unstable first ray is sufficient to correct or reduce her hallux, her associated hallux, or not. And if I get just sufficient manual compression, I can reduce the first ray. You can see there they become parallel, and I can actually reduce the hallux to be concentric onto the first ray. Then I think that yes, a lapidus might be a good option in this case. And so this is what I decided to do. I decided, just for the sake of the first ray and the instability of the flat foot, I might add in a lapidus, which would also correct indirectly the hallux valgus deformity, not only the flat foot, but also because as you can see there, the sesamoid, the lateral sesamoid, is still partially uncovered. I thought she might do well with also modified McBride soft tissue release. And that's what we did. We reduced it, we held it. And I'm not going to bore you with the technical details, but I temporarily fixed them. And then from there, I go through the normal lapidus, as you would all define the tibialis anterior tendon, go from there, distract the joint, do all the reefing procedures. There's the position on table. I still always have that clamp in position. This is just not going technically, but I just wanted to deliver the concept that you can also correct this by just the lapidus and the modified McBride. And of course, we put on I'm a big advocate of the plantar lapidus plate. It's a great instrument. It's anatomical. You have that transfixing fusion screw, and I maintain that first ray. And these are the immediate post-operative X-rays. As you can see, maybe from the slides, this was just, I think, 6 weeks out, so we are still going to get those weight-bearing X-rays that we should, and see photos of her standing. But these are the intraoperative corrections right there. So you can see, in contrast, the right foot with the left foot. And this was at the end of the actual end of the procedure. So I'll just stop sharing the screen there, and let's go back to the questions or question regarding this case. Luke, what would you have done differently in this case?
I don't think I would have done anything differently there other than to ask you, did you focus on triplanar correction of the first metatarsal? In other words, rotational correction of it?
Yes, absolutely. If you noticed on the intraoperative, after I do that transverse compression, I also rotate the first ray just a bit, and that's where my second K-wire holds that first ray to the second, yes. So it's that transfixing secondary. And actually, if you put it into the first metatarsal, you'll find it's a bit elevated. And then when you do your rotation, it just kind of comes down again. And you've corrected that rotation, of course, absolutely. And that's actually why I thought about the sesamoid axial view, to see how much of a correction I might need. Yeah.
Exactly. And then just as an aside, now, will you continue to support the correction that you've achieved with orthotic management or orthoses management in her shoes for X amount of time? Is that standard part of what you do, Nassif?
Yes, absolutely, because we all know that the greatest enemy for a lapidus, a well-done lapidus, if I may say so myself, is non-union. And if you do that and it all falls apart, then you're not going to be getting anywhere. And so that's why I'm very meticulous in the preparation of the articular surfaces. If you saw there were little drill holes on both sides, I do that. I now add autogenous grafting, maybe even some gel. I use even PRP derived from the patient when she's there on table. I do everything I can to have that first medial arch, that lapidus fused, and I would keep her up until I can see radiological signs of union, and I can see those marks going across, even in spite of the plate. That's why I also like the plantar plate, because you can actually see the fusion much better than if it was there stuck on the medial side, and you're guessing as 6 weeks, which is all our orthopods. We use these 6-week number, and I usually tell the patient, I'm putting you in a boot, and the minute I tell you to walk out of the boot, you don't listen to what I say. That's the only time you don't listen to what I say, and you move and you keep in that boot for an extra 10 days, if not 2 weeks. So yes, absolutely. I use the medial arch support with the boot, with an air walker, which she will not walk until she achieves the union, yes.
I'm also curious, real quick, is how often you either stress or put some internal fixation between the first and second metatarsal bases, or alternatively, first metatarsal to the intermediate cuneiform?
That is an absolutely gem of a question, because I learned by mistakes, and I have noticed along the years doing these that if to get an additional support of your second cuneiform, that kind of stabilizes your medial column more. And if you see X-rays of patients, even after they have a very good fusion, you might see that little opening up of the medial and the middle cuneiform. And I think that plays a role into the pain they might get on the plantar Lisfranc ligament, and also it affects the foot itself. So yes, I think I'm trending more and more now to fuse the first with the second. There is a question, of course, if you're going to fuse it and the joint is not particularly arthritic, as in these cases, they most often are not.
Yeah, I can just share that I have had recurrences of my own, even 2 years down the road, when the patients come back to see me after I've done a lapidus. And unfortunately, I'm disappointed to see that I've had a recurrence. And even though the first TMT joint was very well fused and so forth, but alignment has drifted and recurred. So there's definitely some intercuneiform instability potentially there. And even lapidus in the original description by Paul Lapidus ages ago, he prepared in between the first and second metatarsal bases to try to get union there as well.
Well, that's a very interesting point you bring up there. Do you actually prepare? Because I know some colleagues that do not actually prepare the joint, and they just stick a screw in there between the first and second, especially if you're doing through the plantar or a more plantarly directed incision. What are your thoughts on that, Luke?
Well, my thoughts on that are it's better than nothing, but and it's probably technique driven because the incision for the plantar plate is more medial. But my preference is to try to prepare that area, even if I had to make a small ancillary or secondary incision there. I just think it improves stability, improves your osseous fusion mass, and just really gives you, I always call it belt and suspenders, and one of our UK colleagues told me one day they call it double-breasted. But so it's a double-breasted repair or belt and suspenders to ensure that that area is not going to drift, particularly the transverse plane.
Yeah, critical, great. On a double breasting, now you mentioned it, there's a question here by Dr. H, that's how it appears. Have you ever felt the need that the normal subtalar eversion of 15 degrees would be lost if you put in a stiff spring ligament? I think he's referring to a correction of your spring ligament with a brace. And as compared to just a pants over vest or a double breasting repair of your spring ligament, which would preserve, in his opinion, the normal elasticity of the spring ligament. Now, I'll just start off by answering that before Luke, if you don't mind, Luke. When you repair, you have to repair your static structure. That is absolutely vital. Now, the bracelet does not compensate for the repair of the actual biological tissue. What the brace does, it acts as a restraint. It acts as a safety belt. When that tissue starts to tension out or to be under a certain amount of tension, it kind of stretches out there. So you actually put in the brace a little bit relaxed, if you will, than the actual correction you would have done with the spring ligament. So no, you do not over-tension it, and you certainly do not want to lose the subtalar eversion because for the motion of the foot. Luke?
I agree. You don't over-constrain it, and really I don't see how it could over-limit eversion of the calcaneus. To me, really what you're doing, it's almost like an AO principle of bringing an unstable fragment of a fracture to the stable fragment. Okay. And I see it really as cinching the distal component back to the more stable area of the sustentaculum tali, but I don't see that really affecting overall subtalar joint eversion of the talocalcaneal complex.
Okay, now there were a lot of questions here, and Dr. Orphan was one of them, that he wanted to ask about this algorithm we had, and when often would you perform all three osteotomies in his opinion, the medial calcaneal displacement, the cuneiform, and the cotton osteotomy, for example, in cases of Flatfoot. And I think this is a good time to bring up the algorithm, and then we can have maybe a few more minutes for a few more questions, because I can still see some questions are coming in. So I'll just share my screen here quickly for this algorithm, if you will, that just me and Luke, we kind of came up with. Now, a few disclaimers here. This is not actually, is that showing fine?
Yes, your slide, I see your slide fine.
Yeah, so this is not actually like this is the only thing to do. We have omitted the conservative treatment. We have omitted a lot of double procedures. What we're trying to give you is our main procedure, if you will, and how we go about choosing that. So, of course, if you're starting off with a flat foot, we do know these are adolescent or adults. And if in the adolescent, as we just decided, if there are no symptoms, you don't have any treatment, or if there's symptoms, then you can treat them. In the adult type, there's the posterior tibialis tendon dysfunction, which is the adult acquired flat foot. And some of these might be carried over from adolescence. So they had asymptomatic flat feet when they were younger, and now they're starting to symptomize over when they grow up. This is not dogmatic. This is just a simple, brief overview to give you an idea of how you might think about it. So, as we said, the adolescent, no symptoms, no treatment. If you have symptoms, I think then you would look at the flexibility and the deformity of these cases. So, if they're not flexible, if they're not correctable, then you can think it's a coalition or a congenital tapes equinovarus or a neurological insult, and you can treat that accordingly. However, if they are flexible and correctable, mind you, these are symptomatic, then you would think according also to the deformity. Is it more of a flat foot, so a medial arch collapse, or is it more of an abduction? And if it is more of a flat foot, then you would think along the lines of the arthroeresis for the hind foot, a medial arch support, or a kidney if they have an accessory navicular. Whereas if it's more of an abduction, then you might think along the lines of the lateral column. So this is the way we kind of think of approaching an adolescent flat foot. And there is just that end slide with everything in. So you guys can just look at it for a while. Now, if we move on to the adult flat feet, as we said, there are PTTDs or carried over from adolescence. Now, this particular adult-acquired flat foot, or the tibialis posterior tendon dysfunction, there have been several types of staging, we all know. If it's a stage 2A or B Johnson-Strom, which is a pretty old classification, or the Grand Rapids arch column collapse theory, the stage 2, because these are particular in that they might need that soft tissue. So you might want to factor in a soft tissue repair, the FDL, the FHL, plus or minus a spring ligament repair or augmentation with your correction of the hindfoot valgus with an MDCO. So these are an entity in themselves. Of course, if you have the previous stages where you might even want to do a tenoscopy for the PTT or the conservative treatment, we're just trying to highlight certain points in particular diseases and where your procedural choice might change, if you will. Now, if there are others, but others obviously that are stage 2 onwards, then you might think along the predominant plane of deformity, as Luke was alluding to. So you would look at the foot and see weight bearing, of course, or non-weight bearing, and you would factor in what is the main plane of deformity. So is it more transverse? Is it more medial column? Is it more frontal deformity? And then you can choose, if it's a transverse deformity, then you would be thinking of your Evans or your calcanea cuboid joint distraction arthrodesis. If it's more of a frontal deformity, then you can factor in an MDCO or an arthrodesis. And there have been questions, would you use an arthroeresis in an adult? Yes, you could, but never as a standalone procedure. So you might want to do that in replacement of an MDCO. Say you're going to do an Evans and you don't want to increase the incision, you might think of doing an arthroeresis. I would just caution you that you cannot do an arthroeresis over onto an Evans in particular, because then you're doing the osteotomy almost right beneath where your screw is going to lie. Now, the other part is if it's a sagittal or medial column, as Luke is a very big proponent of, so you would look at the x-rays, the standing lateral x-ray, and you would look at particularly, because not all flat feet are the same, and as Luke likes to say, it's not n equals 1. If you have patients that have a navicular-cuneiform sag, and you will see that break is in the navicular cuneiform, then you might think about doing the NCE fusion. If, however, like in the case we just showed, there's a hallux valgus with a first ray instability, you might think of doing a lapidus. And remember, these are not just standalone procedures, you can factor them in. If neither, so they're neither a hallux valgus or neither a first ray instability or a navicular cuneiform break, then you can think about factoring in the cotton osteotomy, especially if you have a residual forefoot supination. Any one of these three, on the medial side, you can also add a spring ligament repair or augmentation. So just as a final thought, there's the final procedural choice, if you will, for an adult flat foot deformity. As I say again, this is not the absolute way to go. It's just a way to broaden how you think about choosing a certain procedure. You can choose and pick whichever you think would work best for your patient at that particular time. So I think I hope our fan that answered your question in the procedures. I'm just trying to escape from my screen here and not share my screen. Yes. Okay, so I think I'm back. Am I, Luke?
Yes, I see you now. Yep.
Okay, so you have any thoughts on the algorithm? We have a question here. Do you have a preoperative plan for the amount of medial calcaneal displacement in a type 2 flat foot based on the amount of hindfoot moment, arm, or valgus? From a Dr. H.
Yeah, so that's a great question, and quite honestly, I do not have some sort of method to calculate. There was an article published years ago in a podiatric medical journal by Tom Rukas, which I thought was quite nice, showing how intraoperatively you can sketch the subtalar joint axis on the plantar aspect of the foot, the plantar heel, and into the midfoot, and then you can palpate. You can actually, cut your osteotomy, shift it over, provisionally pin it, and then be palpating medial to lateral and seeing where the foot stops having a supinatory moment. It stops having a pronatory moment and becomes supinatory. And then you can kind of try to estimate as best possible just how far to shift the heel over. I go for the standardly understood 1 centimeter of shift. I will say one thing in regards to that, and why doesn't seem like anyone's asked, but one of the reasons I put in that subtalar joint fusion case and I did not do a calcaneal displacement osteotomy on her, was yes, she had some mild arthritic changes, but they weren't end-stage arthritic changes. But I have seen higher BMI type individuals pronate through calcaneal displacement osteotomies, and I would caution folks that as patients start getting larger or have are obese or higher BMI, that many times I think it's better to stabilize the hindfoot where you want it with a subtalar joint fusion, even in the absence of perhaps advanced arthritic changes, rather than depend on a medial calcaneal displacement osteotomy to control all those forces and pressure being force over square millimeters and so forth. So be very careful. I've gotten burnt in that early on in my career and been disappointed with the amount of durability of just a medial calcaneal displacement osteotomy. Better to do it.
Speaking of which, Luke, is there a limit on the obesity, the BMIs that would allow you to operate or not operate upon on certain adolescents and in adult flat feet? So, in other words, is there a BMI you would not go beyond in saying, okay, I'm going to have your feet fixed or not? Is it a limiting factor? We do know it's a cumulative factor. It does not in itself cause the flat feet, but is it a limiting factor for you?
Well, I can't give you a number, although I should do some homework on that, because it seems to me in the last year or so I've read an article regarding BMI as it relates to postoperative complication rate.
Yes.
Okay,
That's what I was referring to.
Right, specific to our subspecialty here of foot and ankle, no. But I will say that my goal is to try to help people return to a higher level of function and activity than they were preoperatively. So if I feel like a patient whose BMI is just too high, or they're just too obese or deconditioned, that even stabilizing or improving their flat foot is not necessarily going to be that magic step back to them resuming a more active lifestyle, then what I will do is I will not operate, but I will really cheerlead and coach them into what I call prehab rather than rehab, and encourage them, well, listen, let's dedicate 6 months here to seeing how much we can optimize your own physical fitness. And maybe you can drop 8 kilos or 20 pounds or something like that. And then that gives us a better chance to give you a more functional result. So to me, it's just like the blend of the art and the science. It's a subjective assessment on my part.
Okay, Luke, that's been great. And I think we've answered more or less most of the questions that have come through. So, Mike, you still with us?
Yep, I'm still here, guys. Thanks very much for an outstanding session. We had another repeat, large component of people joining us. We had 400 yesterday and over 300 today. So very impressive, and thank you very much for your time, and thank you for a very engaging conversation. I think we covered a lot of topics. For anyone who's still on the line, we have that open email address, orthoengage@gmail.com. So any questions that you feel like weren't answered, please direct your questions there, and we'll be happy to pass them on to our faculty. So guys, once again, thanks so much for your time, and we really appreciate your efforts. Thank you, everyone. Have a good afternoon.
Thank you, Mike. Thank you, Nassif.
It's
Wonderful.
a pleasure. Thank you both. And guys, look forward to the rest of these webinars. They're really good and informative. I personally learn a lot every time I look at or listen or engage in one of these. And everyone stay safe.
Thank you. That was wonderful.
Thank you, guys.
Thank you very much, gentlemen. Cheers.
Bye.
Cheers.
Ciao.
Bye.